Hi, everybody. Welcome to Experts Dig In for Doggies for Dementia. I am Carmen DeValis, founder of Doggies for Dementia Foundation, and I have a wonderful guest today, Cindy Pelan, who works with Tranquility Hospice. And we're going to talk about hospice today, hospice in relation to dementia. So welcome, Cindy. What can you tell our audience about what you do?
Oh, hi, Carmen.
Hi.
As Carmen said, my name is Cindy. I'm with Tranquility Hospice Care in Georgetown. My role with the hospice care is to educate the community, physicians, whomever will let me talk about hospice, really. It's a passion of mine that I've been working in hospice for about 15 years now, and just really feel like this is where I'm supposed to be.
Wow, 15 years. So lots of changes too, I bet.
Yes, there has been.
Yeah, yeah. And that education piece is so key because I know there are a lot of myths surrounding hospice. I've heard them myself, and
Yes.
having worked in the medical field, I hear it even from medical professionals. And so great. I'm so glad we're talking about this. So we're going to get kind of clear on, we're going to talk today about hospice, in particular to dementia, people with dementia and their families. Correct me if I'm wrong, but there's a difference a little bit with approach as far as other people in hospice for other reasons, or is it about the same?
There is some difference just because of obviously their cognitive abilities. And so, we do have a different approach, especially with the caregivers. Most caregivers wait until the very last minute, and by the time they have said, okay, it's time for me to get help and get hospice care, they're so worn out and so tired. We work with the caregivers just as much as we do the patients.
Oh, I'm sure, because they are your clients too. They're the ones that are caring for their loved one and need a lot of support. And I hear what you're saying about waiting maybe a long time. And maybe part of that is not quite knowing when is the right time. What does hospice do so that we would know it's the right time? So, maybe we can just kind of take, let's just have let's say there's a person with dementia who, when would be a time to consider hospice? Like there's some criteria or?
Yes, there is some criteria on the Medicare Guidelines. That would be the patient is no longer able to put 5 intelligible words together. They've had a weight loss in the last 4 to 6 months. Their inability to move around on their own. And again, they're dependent on all of their ADLs, which are assisted daily living activities. So
like brushing teeth, washing their faces,
correct.
taking baths, stuff like that. Okay.
Yes.
Feeding themselves, that would be a big one too. Yeah.
Right, that is a big one. Yes. Okay. But that and other people have comorbidities that would also allow them.
So like other illnesses on top of
correct.
Dementia.
Yes.
Yeah, diabetes and heart disease, high blood pressure. Yeah. Okay, so thinking about those things, then a person with dementia might be on hospice for quite a while then. Yeah, because that stage of dementia can last a while.
Yes, it can. You're right, Carmen. And it, every individual is different based on, their underlying illnesses that they have in addition to their dementia. So, as long as, that physician does say based on everything that's going on with this patient, and if they continue to decline with that disease, it could be, a prognosis of less than 6 months. But we've had people on for a year. Again, it just depends. If we have a dementia patient and they get a urinary tract infection, they may have this significant decline, but we're going to treat, with the antibiotics and they'll get better. So,
right.
Yeah.
And I recall patients of my own when I worked as a nurse practitioner that actually thrived, did better with the more help and things that hospice provided, and kind of graduated out of hospice.
Yes, that's correct.
Yeah.
We just a matter of fact with Tranquility Hospice just recently last week we had a patient that graduated from our services, and her daughter was like, it's because you guys were there. You know, she got that extra attention. She did live in an does living in an assisted living, but you know, we were in there more often. You know, so.
Right. Yeah. And for the most part, what I have heard from people who, and when I talked to families and talked about hospice, it was, we're going to talk about myths in a minute because that's huge. But the flip side of that was how grateful people were for they had no idea what hospice was going to bring to them as far as more support, someone to call when they needed it, more help at home, just a variety of things that made their role as a caregiver so much easier, so that they were also had time to just love their family member. You know, if given a choice between being the caregiver and a loving spouse, for instance, it gave them more time and ability to be that loving spouse more than a caregiver.
Right. That's very, well said, Carmen. And that's what I, tell families as well, that same thing. Let us help care for them. And, you become their spouse again.
Yeah.
And not the caregiver. So.
Yeah, I don't even think I can say that big enough how important that is to think about. And I know when we're in that caregiving role and we're focused on caregiving, we forget sometimes that it's important to be that daughter again, or wife or what have you. And hospice was wonderful for that. And so let's take that same patient we're talking about and they meet the criteria. Then hospice comes in. What does hospice typically then do? You're talking to me, what are you going to do for me then?
Right. So the first part of a hospice is, we do check the criteria, make sure that, the patient does meet the Medicare criteria for hospice. And then the first step would be we have to get a physician's order. Physician's order before I can go out and really talk with the families and the patients about hospice and what that looks like. So from there, we have a nurse who does the actual admission. So she would do an all-over assessment so that we have a baseline, for this patient. And then we our agency offers visits, nursing visits twice a week. We have an aide that goes out, a CNA goes out 3 times a week. We also offer spiritual care and a social worker that could assist in many ways, whether it's with the patient or the family, maybe they need some resources. And so they play a big role as well in all of that.
I bet. We've had a few guests that are talking about what happens when siblings don't agree and that they're, to bring in someone to help mediate that and, to acknowledge each side and say, now let's come to an agreement. It's huge and so important. Again, so we can go back to the reason that we're caring for our loved one is because we love them, right? And we love them enough to fight for our ways.
Right.
Is right. Yeah. So, oh my gosh. And then the CNAs that come in, so they're helping with the bathing and helping get up and, changing the bed linens and things like that too. Yeah. Okay.
Yes, ma'am, they do. And, they become very attached, because they see them so often, you know. And the CNA is also eyes and ears for the nurse, the days that the nurse isn't there, if they notice something that's changed or something different, they stay in very close communication. So,
how wonderful
it's a very
is that
much
then?
team effort. for sure.
Right. Right. And to support the family and for the person with dementia. Yeah, what a beautiful thing then. So, I'm going to just kind of squash this happy moment and talk about the myths. And they're
Okay.
like one of the biggest myths. And, I'm going to say I have not only heard this from my own family members or from other family members and even healthcare providers. And just to be blunt, the comment is, and I think it goes back to hospice maybe in the earlier days or ideas, but hospice is what you do. You call them in when someone's ready to die, because you're not going to do anything to help them other than kind of hurry the death along.
Mm-hmm.
Which is, I know you've heard that, yes?
We have heard that. And along with that myth is you're going to give them morphine and they're going to pass away right away.
Yes.
And I, when people say there's nothing more that we can do, there is always more that we can do. We can help that family and that patient get to where they want to be and where they need to be. So I don't like it when people say there's nothing more we can do, because there's always something we can do.
Right. Maybe there's no cure, but there's certainly ways to care. And
right. They're just changing their focus. They're changing the focus from that curative treatment to the more comfortable treatment, or not treatment, but there's no cure, so let's focus on the care.
Right. And, I think some of those myths are wrapped around our fear of end of life and how we look at death and dying, and, that time of the time of the life that we're all going to get to, right? We don't want to think about it. We really don't want to think about it, but it is important. And what's that going to look like? And I think then hospice kind of allows the family to think about that and to live through that in a way that they're going to look back on and feel that it was the best for them. Yes.
And that's where the role of the spiritual care person and the social worker can really be of help. Maybe mom and dad haven't really talked about it. I used some recent cases. We had a couple that really, she was ready, he wasn't ready. But with them, by us getting on board and then having our social worker and our spiritual care come in and speak with both of them, he then began to, not trust, but he understood that it wasn't because she was angry with him and she wanted to leave, but it was more she was tired, and so he was more accepting of it after that help with the social worker, and spiritual care.
Yeah, that's really important. I don't know if you know this or not, but one of the big inspirations for me was an epiphany one day in the clinic that to stop and when I wrote my book, and to leave the clinic world and to do something different. But it was a couple, a husband and wife, and they had come in together and were crying and holding each other. And she had early onset Alzheimer's, but was more in the beginning stages, beginning time, but she could feel she was starting to lose certain abilities. And she came in and said, I know you're not going to do this for me, but I have to beg you. I want to be with my husband now and look for hospice care for when the time comes, so that I can help him and know what questions to ask, and to maybe choose what's going to be the best one. Because otherwise he's going to be choosing without me being able to contribute. And I don't want him to be left out on his own with that. And of course I was able to accommodate that. I got on the phone right then, and we speaker called, and we set up these appointments for them to chat with the social worker and even the spiritual care. I wanted to say advisor, but that's not the word you spiritual. What's the title for the
spiritual care coordinator? Spiritual.
Yeah, because it's body, mind, and spirit, and death is a sacred time too. And how do we handle that? And
Right.
that demonstration of love around that husband and wife was just so profound to me that,
Right.
I was
That's
thinking, I'm
great.
like, I don't know if I've
Yeah.
ever seen a true display of selflessness and of love.
Mhm.
That they had done that, and it was really scary for them, but she knew it was
Mhm.
important.
Right.
And
Yeah, and Carmen, we've had a few people that have reached out to us that are not appropriate at this time, but again, wanted the information, so
yeah,
they have it. They're, and they keep it wherever,
yeah,
with their files. But at least they've reached out. They've made that initial call, that initial visit. They've gotten the information. They know what to look for when maybe that time has approached that this person would now qualify.
right.
Yeah,
Yeah,
that's part of what I do as well. Is again, that's the education part.
and I don't know, I would ask you how you feel about this, but in when I was in the clinic too, I encourage that, because I think that at a crisis time, when the caregiver, especially if they feel like they may be waiting too long, when they're in
Hmm.
crisis mode, is the most difficult time to make good decisions.
Right.
And that if those decisions are made ahead of time and everyone's on board and understands, then the plan is already somewhat set in motion, right?
Correct.
And they've
Yes.
already discussed it, and they know, and rather than waiting until
Hmm.
that
Yes.
time. And I know that's wrapped around the thought that if we go on hospice, we're saying we're done trying anymore, which is really kind of the opposite. It's like,
Exactly.
we want life to be better
Right, right. We
now.
encourage, our patients and families to, you know, that's why we're there. It's not about giving up. It's about making each day more important. And if there is some discomfort, making sure that they're comfortable and doing the activities that they're still able to do.
Mm-hmm. Mm-hmm.
So one day at a time. But it is definitely helpful for them to hear that it's not about giving up. It's about um, making each day and living it to the fullest.
Right. And so while there are hospice, say, community or facilities per se, designate, for the most part, people are either on hospice at home or in assisted living or memory care, wherever else they might be getting care. Is that correct?
That's correct. Yes, there are personal homes. There's personal care homes. There is, like you said, the assisted livings and memory cares, um, and independent living communities also.
Mm-hmm. Yeah. So wow, thank you so much. And I'm just
You're
wondering
welcome.
if, yeah, I'm thinking like what else might our followers want, questions they have. And I'm gonna leave that open for the comments, because I know we're gonna visit again. And
Okay.
for other comments or questions, or if there's anything you would like to add, this is a great time. What have we not
Right.
covered with hospice? And oh,
Right.
how about payment? How do people pay?
Oh,
That's an
very good.
important thing,
That's
right?
an important thing, Carmen. Yes.
Yeah.
Most of our patients are on Medicare. It is covered by Medicare at 100%. So there is no out-of-pocket deductible. And we didn't talk about what's included with that benefit. So along with the benefit and the clinical team that you have, we also cover any durable medical equipment, whether it's a hospital bed or walker, wheelchair, um, oxygen, if the patient is on oxygen. We cover incontinence supplies, and we also, wipes, gloves. We also cover any comfort medications that the patient would need. Um, and I'm kind of jumping around, I apologize, but this kind of goes along with a little bit of the myth
Right.
around hospice, is that, I hear people say, well, they're, they're just going to take me off all my medications. I'm not going to be able to take any of my medications. And that's
Right.
not true.
Right.
You know,
Thank you for bringing that up, because that is
yeah,
something.
right. We never take that away. You know, there comes a point where people don't want to take them anymore, or they're not able to swallow. So, you know, we look at all those things, and the case manager really works with the family on that. The other myth, Carmen, is that I have to sign an out of hospital do not resuscitate when I'm on hospice. And that is a myth also. So some people just aren't quite ready, you know, to sign that document.
So let's explain that to me. So out of hospital do not resuscitate means that if they stopped breathing or their heart stopped, you would still do CPR.
We would not do CPR.
You would not do CPR.
We would not do CPR. So, and the reason we have those in place is if when the heart, you know, patient passes away at home, and let's say there was a different family member there and they called 911. If that out of hospital do not resuscitate is not in place, the paramedics are required by law to do whatever they can to try to resuscitate the patient. So that's why it's important, if you don't want to do that, you know, to have that in place. And that's something that I work with the families on that want one, or a social worker can also help with that.
Okay.
So
that's another really important thing for all of us, really. What do we want done, right?
Right, exactly.
And I just thought of another one. So let's say we've my loved one's on hospice and I'm caring for them, and they develop a bad case of pneumonia. And I'm like, you know, they've been doing okay, but now they need IV antibiotics. And it's recommended hospitalization to get it started, and then they would come back home. Is that something that someone on hospice can be hospitalized for a different reason than they're on hospice?
While they are on hospice, we would try to treat the symptoms as much as we could at home. And we do not do IV antibiotics. If the family chose to take the patient to the hospital, they revoke from hospice services, go to the hospital. That's considered an aggressive treatment. And so then when they came back home to, you know, wherever that might be, they can come back on hospice. Okay. So again, hospice is not a one-time benefit. It can be used multiple times.
So that's good to know. Yeah, I know personally I would do everything I could to get the antibiotics on board, and you know, whatever way that we could. And I want to say too, I think there were times we had home health in temporarily to administer the IV antibiotics for short term to get it up and going. Maybe the person couldn't swallow the pills or the liquid or something, but they were really struggling with the breathing, and we were trying to, you know, resolve some of that pneumonia so that they weren't struggling to breathe and things.
Right.
I know that's a case by case also, but
yes, exactly.
You know, it comes down to that comfort and what we can do for comfort. Yeah. So yeah, and there was something when you were talking I was thinking about, and then I forgot. I know. So case scenario, so what you're saying then for hospice is, let's say I'm at home and I'm doing my best I'm doing some heavy lifting and I'm managing on my own, and whatever help can come in. So hospice would come in and get a hospital bed, supply the adult brief, so the pads for the bed and all the things that are needed around, you know, the incontinence care. And I would have a nurse's aide come in 3 times a week to help with the bathing and things. And so I could get a little break on that. Also.
Yes.
And it's covered by Medicare, so there's no out of pocket for these things.
Correct.
For me. Yeah.
Correct.
Yeah.
And, you know, family members who have, you know, want to keep their their loved one at home, a lot of times they'll bring in additional care, you know, private pay home care agencies, and that's something our social worker can help with that also.
Right. Yeah. Yeah. So that option's always there too. Wow, that's fantastic. Yeah, and how important that is in the world of dementia care when so many families are struggling to care for their loved ones, and
right.
it provides a better way for them to to do that. And
Mhm.
yeah. Well, thank you for that. I have one question for you at the end.
Okay.
And you know what? I don't think I warned you about that. So sorry. Sorry, Cindy. Yeah. So, So, okay. So, Cindy, what single person has influenced your life the most?
I would say it's a couple different people. If it were for hospice care, her name is Susan Willett. She's an LVN and just taught me so much about hospice care. And then as far as just in general, it would be my grandmother.
And she influenced you?
She just influenced me on going out there and doing the best you can every day. So, and she passed away about 5 years ago. So yeah, she was a huge influence in my life.
Oh, that's wonderful. Well, thank you, Cindy.
You're welcome.
Cindy, and your contact information will be in with the description here on YouTube. Okay. On the comments, but it's Tranquility Hospice. So we are in Georgetown, Texas. So in case because there are people from all over the world listening, we're in Texas, where things are about to get opened up again. So yeah. We've been on some quarantine stuff, but that's passing. And I welcome everyone to write your questions in the comment area so that we could revisit and answer those, because this is a really important topic. And we're talking about quality of life for both families and for the person with dementia, which is, quality of life is important.
Right.
Yeah.
Thanks for having me, Carmen.
Thank you, Cindy, and thank you everybody for watching. Take care. Bye-bye.
Bye.